Well, hi everyone, and welcome to our video roundtable, a very special collection of experts that we wanted to bring to you. And we're looking forward to talking today about the patient journey, and especially about listening to the data along that patient journey and what we can learn. What the data analytics and health informatics tell us about the path to finding better health for patients. And just so glad to have today to have a panel of experts. And I want to introduce our panel. We have Kimberly Curry. Dr. Curry is a PhD in informatics. She is an expert in the area of data and a CEO of a consulting company called Inventec. And also with us is Dr. Michelle Hamlin, also PhD in informatics, and works with Kim in the area of technology at Inventec. But together, both Michelle and Kim are in the informatics department of a major hospital system, multiple locations, large beds, integrated system with both providers and hospitals and clinics. So they have a very good perspective on how informatics is working in the institution. Kim and Michelle, just so glad to have you.
Thank you.
We also have Dan Eds. Dan is the principal of a consulting company called Praxis Solutions, and he does specifically strategic planning for healthcare organizations, and he's the author of a great book called The Genetics of Leadership. And Dan, we're looking forward to your perspective.
Great, thank you. It's great to be with you.
Yeah, and I think in this area of how data applies to leadership and strategic planning, it's going to be a great conversation. And then we also have with us Mike Zangrelli. Mike is head of product management and strategy at 83 Bar Inc. 83 Bar is a patient recruitment agency. Mike, glad to have you with us.
Oh, great. Looking forward to today's discussion.
Yeah, and I think together, all of your perspectives and all of your experiences in this area of data analytics and health informatics is really going to be great. I guess listeners, I also want to thank Mike's company, 83 Bar, for being the sponsor of this video roundtable. And as I said, this area of patient recruitment, plus other services that help educate the patients and empower them to seek a better treatment option. So in the context of what we're going to explore today, certainly what the data says about health-seeking consumers, we always call them patients, but long before they're actually patients, they're just consumers looking for a better health solution. And then we're going to talk about how data and informatics might measure that journey and track that journey. And then most of all, how to better manage and maybe accelerate that patient journey so the patients don't have to wait so long, because so many patients are waiting for a better solution, and we want to get them the care they need. So maybe, Michelle, I could just start with you around that topic. And that is, when we think about the patient journey and all the elements thereof, from the health concern all the way to the treatment and then perhaps the outcome, what are some of the things that health informatics can track? What can we measure?
Sure, it's a great question, Mark. And I appreciate that context of, we're from a healthcare perspective, we always think of these as patients, right? But they're really people outside of the realm of healthcare. These are just consumers. They're people that are trying to manage their own care. And so from an informatics perspective, how we can really support this patient journey, how we can really support this person-owned journey is helping to facilitate the management of their care through, tracking diagnoses, tracking their treatment to that diagnosis. So how is the patient adhering to their treatment guidelines? There are some conditions that a patient has that we have very regimented guidelines and treatment protocols that facilitate best patient outcomes. And we know that because of the evidence. It supports, treatment X for CHF, or, treatment Y for stroke type patients. And this is all data that we're constantly collecting in the healthcare arena. And that is data that we can use in machine learning and AI to really support the patient's overall journey. Again, looking at their outcomes. Are we achieving those outcomes that we're looking for? And I like that concept. You kind of touched on it a little bit, is we shouldn't be waiting. We shouldn't be waiting for the patient to get sick, or we shouldn't be waiting for the patient to have some sort of acute disease state. How can we use that data, that information, to really be more proactive in getting these patients the care that they need before something acutely ill, they become acutely ill and they end up in the hospital, because that's an expensive bill. So what can we do? How can we leverage patients' diagnostics, their laboratory testing, in some instances, genetics? Genetics, genomics is becoming a big thing in the healthcare arena. How can we leverage all of that information, the machine learning, the AI, to support more preventative care, so that the patient's overall journey is a positive experience?
When you mentioned protocols and evidence-based medicine, I was curious if that does help be more proactive. I mean, do the protocols guide the providers to be, more proactive and less reactive?
Definitely, there are some evidence that supports, preventative type medicine, eating healthy, diet, exercise. Those are all preventative protocols that prevent cardiovascular disorders, strokes, those types of things. But unfortunately, we know that some patients or some people don't adhere to those guidelines. So we also have to have protocols for when patients slip through those cracks and end up becoming acutely ill. We know that those circumstances happen.
And I know that informatics, the issue of readmissions, if the treatment doesn't go well and the patient has to come back to the hospital, but even physician office repeat visits, and even worse, ER repeat visits, that some patients are still using the ER almost like a urgent care, primary care. What effect is that having?
Yeah, so we think about the patient journey in two different contexts. One, from the patient's perspective, we want to try and keep them out of the hospitals as much as we can. We certainly don't want them to get readmitted. Every time they're going into a healthcare setting, especially in a hospital setting, they're at an additional risk. So we want to try to avoid that as much as we can. On the flip side, though, is more of a healthcare perspective for readmissions. The readmissions is heavily regulated. CMS really scrutinizes how often our patients are readmitted into the facilities, and then we get reduced reimbursement, and then it's really costly to organizations. And so it's kind of a twofold: one for the patient's perspective, and one also from the healthcare perspective. Again, that the informatics, from the informatics perspective, and this big data, this concept of big data, what does the information tell us? What does the evidence tell us that really supports preventing these patients from getting readmitted? Are we following the treatment protocols in the hospitals to help prevent readmissions from occurring? A patient comes in with sepsis, and part of the protocol is to provide as much IV fluids and hydrations on this patient as possible, but to what risk and what detriment? Some of these patients are getting readmitted because of heart failure complications. They had too much fluid. And so how do we pick up on those before they get discharged? How do we make sure that we didn't fluid overload them to treat one disease and then end up causing another disease that leads to that readmission? So again, trying to leverage that data to support best practices in managing these patients to avoid those readmissions.
Very good. Well, let's bring in our other panelists. What other thoughts or questions or insights do you all have?
Mike, I'll defer to you.
At 83 bar, a lot of our measurement is certainly around kind of pre the visit that we're working on. So it's certainly interesting to learn about what's tracked, in the hospital and in the care facilities. You know, so we focus a lot around the communication and tracking that communication. So I guess maybe one of my questions is in keeping the patients on the protocols and whatnot, what kind of advances in communications with the patients have you seen maybe some success with to keep them on track? You know, everybody's electronic, whether it's text or chat or whatnot. So kind of curious how you communicate with the patients to maintain these protocols.
Yeah, it's an excellent, great question. You know, I think some of it has to do with the patient's accessibility to certain types of services. Not every organization or every state or city may have the resources to support communication efforts. And I find that having designated roles, coordinators, care coordinators, nursing coordinators are really that key to help maintain that communication, making sure that somebody is following up with these patients beyond that acute care or their visit, even in the clinics, beyond just those moments and times where they're seeing a physician. So those programs tend to be a lot more successful, and trying to build on some of our technologies that we have to facilitate that communication. You know, we're becoming that generation where we're dependent on technology. We like our devices, especially, you know, I'm a millennial. We like our devices. So how do we meet the patient's needs? I prefer text messaging, but my grandma may not. So how do we make sure that we are establishing communication that meets the needs of the different populations that we're serving?
Yeah.
Right. And we were having a conversation the other day about advocates for patients. I mean, I think everybody needs, I know I've been an advocate for my grandmother and my parents, and I think Michelle's been an advocate for me when I've been ill or had a surgery. You know, we all need someone to be there, to be that other set of eyes and ears, and to relay information and to help follow up and understand education. And I know that's not so much of an informatics perspective, but that could be accomplished, let's say, with your smart device, with your phone, with FaceTime, you know, with the provider and an elderly patient, you know, being there and being that extra set of ears.
And Dan, I'm curious, when you've been doing strategic planning with the C-suite, how this kind of adherence to protocols, you know, how are we going to get every department to follow what is evidence-based, and how they balance that with also what feels good to the patient and what's going to keep everybody happy?
Yeah, Mark, that's a great question. And I'm sitting here writing down notes. And so Kim and Michelle, I appreciate your comments. To be perfectly frank, I have some real concerns when it comes to, quote, the C-suite. And in this context, as our healthcare institutions get larger and larger and larger and larger, those men and women in the C-suite, the executive leadership, they get further and further and further away from the patient or the customer. And that, I think, is an inherent challenge as well as danger. I can't remember if it was Michelle or Kim, you mentioned, you know, care coordinators. And I've been involved with healthcare institutions that uses those coordinators brilliantly. I've seen others where it's basically a call center. And boy, I don't know. I'm thinking of my 96-year-old mother, and a call center just is not going to work for her. And the other thing that I'm thinking about from a strategic standpoint is where are the connections to the broader communities? Because if we're going to bring people into a healthcare institution in a preventative mode, it seems to me that there has to be intentional connections and relationships, both from the institution as well as the informatics, to the other institutions, nonprofits, government agencies within the community. So one simple example that I actually thought was brilliant, a hospital, small rural hospital that I know, they started noticing the number of falls coming into their emergency department from elderly people. And when they got looking at the data, they realized a lot of these people did not have a relationship with a physician or the hospital. And so they reached out to the one institution that elderly people almost universally value, and that's the fire department and paramedics. And so they set up actually an intentional relationship so that when the paramedic goes into a home or an apartment, they will look for evidence, opportunities for an elderly person to fall. And then they will bring them into, they create that connection to a healthcare provider or to the hospital. And it's, I'm not sure if seamless transition was the right word, but it creates that caring, compassionate connection from, the paramedic or the firefighter who comes in, and we all just, love to see them. We sort of worship the ground they walk on, brings them right into the hospital. And by the way, we start seeing, victims of falls dropping and coming into the emergency department.
Yeah, for bringing all the community resources and a whole different kind of protocol, I think, almost.
Yep.
Yeah.
Yep.
All right, good. Well, Kim, if we could continue this and ask you, in terms of your experience with informatics, how might informatics help accelerate the patient's journey and kind of speeding up this path from looking for answers to a better outcome for the patient? What's your experience?
Yeah, I think the major point is that we have the right patient with the right information treatment with the right provider at the right time. And I think informatics can support a majority of those touch points. I think that empowering patients to become the promoters or facilitators of their own healthcare journey is a great point. And being in just like Daniel was just speaking about, having a relationship with not only your provider, but your organization as well. And being able to share that information across organizations is also important. We have two major healthcare organizations here where we are locally, and it's really difficult sometimes to share information, and those patients see providers at both organizations. So really putting the patient, informatics can support putting the patient in control and helping them lead their own experience and ultimately their journey. I think of a patient journey as comprised of many experiences. And if we can make most of those positive, that will improve their outcomes and their journey overall.
Mm-hmm. And picking up on what you just said about the institutions and the various clinics and providers, I think about that referral pathway. And I think, Mike, you were talking about this communication too, and many of the patients come in, but, how do I get from a primary care doctor to a specialist? And then I have to go to a diagnostic clinic. Then I have to come back. How is that, pathway being managed and measured?
That's a great question. A lot of our, well, at least where we are employed, we are using a system that supports health maintenance. So it is reminding providers and clinicians to talk to patients about maintenance and prevention, which keeps them out of the acute care setting. And with that maintenance becomes referrals, mammograms and chest x-rays for patients that are smokers, those kinds of things, colonoscopies. All of those things have to have a referral. So we support that through the maintenance portion with informatics and getting those patients to the right place at the right time before something acute illness happens. Mm-hmm. And I think then that care coordination as well that we talked about, to follow up, because like Michelle said, her grandma may need a phone call or may need a home health nurse to come and remind her to do something versus a text message with one touch scheduling.
Mm-hmm. But in a system like yours, especially, you know, as EMRs and things have evolved, are you able to track and measure, you know, how many people did ask for a referral to a gastroenterologist? How many
Yes.
people went to 3 cardiologists before they got the answer they wanted? You know, whatever the case might be, or this doctor hopping that we hear a lot about. Are you able to track and measure and sort of document that as a overall thing, not just an individual patient basis? Okay.
Yes, we do look at multiple factors, especially with referrals and outcomes and what those outcomes were. Or if there is a poor outcome, we can go back and look and see where can we improve in our process.
Mm-hmm. Okay.
After we get them the care that they need. You know, we have a large oncology center at our institution, and they're very good about that tracking and following up with patients and creating that continuum of care that leads the patient down every single path that they need to go for a better outcome.
And then do the clinics get that feedback? Like, look, you're seeing patients that you're the 4th doctor they've seen. I don't know if that's helpful to the providers or not.
I have not heard of that information being shared. Have you heard that about how many physicians they see before that they consult with before they choose one? Or
yeah, not necessarily in the clinic setting. We see it a lot in our ER settings. So the ERs, that's one of the big data points that our ER settings look to see how often we're seeing patients go through many different ERs. Well, and a lot of that data, what it shows is that these patients are falling through the cracks. We are not setting them up with their primary care providers like we should. Or we're referring them to a primary care, but then nobody tracks or nobody supports them after they leave the ER. So how do we make sure and ensure that those patients are getting set up to be successful outside of the ED? And so that is a data point that EDs definitely monitor, because again, like you said, you know, patients are using EDs like primary care rather than going to a primary care facility. And so from that perspective, it's leveraged heavily. In terms of the clinics using it, I have not seen personally clinics use that sort of information as widely, presumably because they're not dealt with a high ER cost like our EDs are, and overflow and making sure that you have enough capacity in your EDs. So a little different perspective from the clinic side.
Yeah, I think too that we see a lot of patients, at least in the areas I have worked as a clinician, we see a lot of patients that decline a primary care provider, a PCP. They don't understand the need for having preventative health care. They only go to a provider or the ED if there is an urgent need. So I think, once again, speaking to that relationship and building the trust with your organization and your providers so that you can understand that you do need health maintenance. That's what it's about now, prevention for these patients on their journey. We don't want anybody to have cancer or heart disease. So starting with that piece, and that has a lot to do with education, pushing education to patients when they're ready to see it and when they can digest it, and helping support that relationship.
Mm-hmm. Mark, could I ask a question?
Of course.
So one of the areas that I get involved with or get asked about a lot is institutional learning, and so for Kim and Michelle, I'm curious about your perspective on, you have data. Lord knows we're all swimming in data.
Too much.
Now how much intelligence is coming out of that, it might be a different question. But it really is the question of we have data. How do we take data and actually intentionally embed it into organizational learning? And one of the healthcare organizations that I looked at when I did the research for my book, I thought they did a brilliant job of doing that, of taking the data, improving processes, building those process changes directly back into their operations. But I've seen a number of healthcare organizations where I ask about improving processes, taking the data, embedding learning, everyday learning, And it's like, oh yeah, we have this this library of courses over here that's online, which to me just doesn't make that connection to organizational learning and the data that's there to point the direction.
I think that at least at the organizations I have been employed with, we do take every opportunity to learn, and we do audit, and we do pull data to see where are we missing, what can we do to improve our patient experience, what can we do to improve outcomes, what evidence-based practice can we implement to improve outcomes and quality and safety. I think that some of those organizations that maybe are not doing that as well or have challenges with that, you know, the organizational framework is really burdened by all of the regulations and compliance and trying to get reimbursed. And so or if they have a very busy ED or very busy inpatient setting, it's really hard to focus on learning and implementing institutionalized education based on our own experiences, if they have those many challenges. So I think it really goes back to, you know, your C-suite and your executives and your operations and your leadership to say, we need to look at our outcomes and we need to improve. You know, regulatory compliance, especially with like Joint Commission and CMS, it really helps to foster that, because we're going to lose reimbursement if we don't improve.
Do you see
there's incentives and penalties?
Right,
yeah.
right.
Yeah. Do you see that as much of a cultural issue, that the institution needs to embed that cultural DNA into their operations and their mindsets?
Yes, I fully agree with that. Okay. And I think having a just culture and a culture of transparency really supports that learning. I mean, I have to say that every time there is an outcome that maybe, I don't want to say a poor outcome, but an outcome that wasn't a desired outcome, I do see our institution and our operational leadership looking at why did that happen and how can we improve and how will that never happen again.
Great. Cool.
Yeah.
Mm-hmm. Well, Mike, let's bring the patient's viewpoint in and what you've learned from 83 Bar's work. You know, in terms of the gaps that your data might show, the dissatisfaction with current treatments, their desire and motivation for something new. And as we said at the outset, maybe even engaging and enrolling in a clinical trial.
Yeah, so, you know, at 83 Bar, we're kind of out there putting some surveys and educational material in front of patients, a lot of times before they're even searching for something. And so we get a lot of people who raise their hand and say, yeah, I've been suffering from this. I didn't know there was a different way, right? I didn't know there was a different path. So we deal with several like chronic disease areas, such as overactive bladder or GERD. And, you know, we see large percentage of people who have been suffering for 5, 10, 15 years. They're very excited for the opportunity to get a second opinion or learn more. And so they're certainly active healthcare consumers, right? At some point, their current treatment is not getting them the results that they want. They're looking for something different. And so they're definitely acting as a consumer would, right? Like we do with anything else. So a lot of times we build our campaigns very focused from what is that consumer, customer service standpoint, right? We try to reduce the friction, be kind of clear and transparent in the communications, and then ultimately connect them. You know, obviously we're running these campaigns because we think we've got a better solution, or at least an alternative that we want to offer them, you know, whether it's a specialist in that area or a new diagnostic kit that might be able to screen for something. So all the materials we build are around that. You know, we see people certainly varying levels of interest in how much they'll engage with us. You know, one of the kind of the bread and butter, we talked about it earlier, right, is a call center versus a care coordinator. And to kind of toot 83 Bar's horn a little bit, our call center is made up of nurses. So it's our clinical contact center. And so having a dialogue with the patient, someone who's empathetic and, you know, used to taking care of the patient as a nurse in either in a previous role, or maybe they're still nursing and they're doing a little bit of this on the side, really provides a better level of customer service to that patient that's frustrated. They're able to make that empathetic connection and then connect them on to navigate that patient to where they're looking to go. Throw a couple stats out there, you know, some of our stuff like our bladder control patients, we've had a very long running bladder control campaign with tens of thousands of people that have completed our survey. And 58% of them were either very dissatisfied or dissatisfied with their current bladder control treatment. Before I started 83 Bar, I would have thought, well, how could so many people be dissatisfied? Go to your doctor and say, this isn't working. It's not satisfied. Right. What's happening? So, but obviously that, you know, they're not getting taken care of. So they need to take that more active role.
And Mike, if I could drill down on that navigate word that you used, this kind of bridge between you know, call center and a nurse care coordinator. Is the nurse able to do some of that navigation? Obviously, there's, again, as Kim mentioned, compliance and regulatory and things like that you need to be mindful of, I'm sure.
Sure. I'll hit a couple of those things. So even though our, you know, our clinical contact center nurses are medically trained, we're not actually giving the medical advice over the phone because they haven't really engaged with us as a provider of healthcare. They've given us some information about a survey. We're having an empathetic conversation. Makes it easier for us to kind of ask the right questions, but also not overstep our bounds and whatnot. Then on the navigation side, any of our stuff, it's here's a list of doctors in your area, or here's some information to take to your doctor. You know, one thing I think, Mark, you asked about is how many people want to seek a second opinion. You know, it's a good percentage, depending on how frustrated they are. It might be as high as 50, 60%, but sometimes they just want to take the information to their own doctor, right? They do trust their doctor, but they didn't even know to ask, or didn't even know to ask about something else. So we'll see people, we'll say, hey, yeah, great. Here, let me connect you with a PDF or doctor discussion guide. I think a lot of times it speaks to information overload. We have so much information. You could probably go Google about your condition and read about it for the next 3 weeks, and you don't know which way is up. Hopefully you're not just reading Facebook posts about medical advice. You know, you're getting it from a good source. But you know, our nurses are able to kind of distill it down and help somebody focus. And then when you do go see your doctor, we've actually, the offices where we are highly engaged with the office and get some feedback from them, is they're very happy that our patients come in properly educated, rather than coming in with a notebook full of 150 pages they printed out, asking 10 million questions, right? Doctors are limited with their time, right? I think the others here will know. And so if the patient come in focused, have fewer questions, it takes some burden off the front office staff, it takes some burden off the doctor to have a more efficient patient journey, which hopefully leads to a faster, successful outcomes for the patient.
It sounds like you're really prepping your patients well for their experience. You're educating them before they go in. I was wondering, having that education, you may be providing that education to providers too for a treatment that maybe they didn't know about. Have you heard that from any of your providers, or is this known information usually?
Yeah. I don't have maybe specific feedback from the providers, but certainly to our clients, right, who are hiring us to develop the campaigns. A lot of times we discover a ton of information about their patient population that they just didn't know about. They didn't know what the barriers were, or they don't get the feedback when the patient, you know, does go into the office. When we do have what we call an activation, right, is someone successfully moving forward and wanting to move forward after they talk to our nurses, you know, we'll do a 2-week or a 30-day follow-up. You know, how was your appointment? Did you, you know, maybe a follow-up survey to gather some more info. you know, and so we can take that information back to our client, and maybe they learn about the reimbursement issues or insurance issues, or, oh, there's actually more steps that, you know, the patient might need to take beforehand. But I do think sometimes our clients, maybe when someone's going to their own doctor, some of our clients do want to know, hey, who are those doctors? I can get my sales team to help educate them, right? Because we're not really directly educating that doctor, but then they know, hey, these doctors are seeing patients that would be ideal for our product. I can send my field rep, you know, out to speak to that doctor and help educate them. So I'm very curious to learn more about how doctors and providers do get educated on new treatments, right, and new things, because there's got to be a lot to learn. So.
That's a lot to keep up with.
Yeah,
definitely.
For nurses too, all clinicians. There's
nurses.
You know, healthcare changes so rapidly.
Well, and I think, Mike, you're describing a situation where, you know, and Kim, this is what you were asking, does the patient come into the office and say, I've heard about, or I've been told about, or I have this discussion guide about, and wouldn't that be better than, you know, I saw a TV commercial and I'd sure like the drug that had that one actor that said he was on it. So it seemed like a little bit more educated patient is a good thing for all around.
Right. It definitely makes for a more efficient and effective visit with the provider, since it's such a limited time that they have.
Yeah. So I think, Dan, to come back around to you on this implication for leadership, you know, we've been talking about better outcomes and also a more educated or satisfied patient with their treatment. If they've gone from dissatisfied to satisfied, that's a good thing. But as leadership is often driven by these rankings, you know, where do I stand in US News and World Report? What is my number? Am I the number one this and this specialty? How is all this blending together as they want to develop an approach and a strategy?
Well, that's a great question. And from my observation, I think it's a big challenge. What I see is that executive leadership can, you know, put their attention 100 different directions, and that's just impossible. I'm thinking of a hospital. Actually, I understand the hospital from two perspectives. One, it's consistently ranked as one of the safest hospitals in the country. When I was writing my book, I did a case study on them. They're one of the first hospitals in the world to adopt the Toyota production system. They teach lean all over the world. I'm also their patient, so I see it from both perspectives, and it's actually kind of fun. But they start off everything with a core value of respect. Respect for the work, respect for the patient, respect for the worker. And that drives, that lens of respect is what every decision is funneled through that lens. And so what I see them doing, and both from my interviews with them as well as just as a patient, is that they create an experience for the patient that's really driven off of respect. And I'll give you just one real simple example. And again, it's me as the patient. So a few months ago, I went to see my primary provider, and got done. He said, okay, you need a chest x-ray, and you need some blood work done. And it's a brand new clinic. They'd just moved into the clinic a few months prior, and it's a much larger facility than where they had been. So he said, when you get ready to go outside, and he said, someone will meet you there. And so I open up the door, and there is a woman, and she says, are you Mr. Eds? I said, yes. She says, okay, let's go to your blood work done first. And she escorts me to the lab to get my blood work done. I get my blood work done, and I walk out the door, and here's another woman. Are you Mr. Eds? Yes. Okay, I'm going to take you to the x-ray. And so she escorts me there. And oh, by the way, I have this little thing in my pocket where they are actually tracking me through the clinic so I don't get lost, you know? And that creates a fabulous experience for me as the patient. But I also know that that is driven through this value of respect. So I'm not sure if this particular hospital is so concerned about, winning this award or that award, but they do make safety a priority. And they are consistently ranked by the Leapfrog with A ratings. I think they've been rated one of the safest hospitals in the country, in the last 8-9 years consistently. But it's that value of respect that drives everything they do. And so it becomes a very holistic approach to healthcare for them.
Mm-hmm.
And
I would imagine these are things that can be measured and tracked too.
Yeah.
So you're seeing it as a positive experience, but someone else might be looking at it saying, we got 3 more cases a day because we didn't have people wandering the hall.
Sure. Yeah.
So these things can be tracked. Well, what a terrific discussion, folks. And it's just as I expected that your various points of view would give us a different angle on each one. Data is what data is, but boy, looking at it from the different viewpoints is terrific. I'd like to conclude by having you respond to some statements that often go in these patient surveys, and patient satisfaction and patient empowerment type surveys. And I would just be curious, based on your experience with both data and informatics, and of course, living it in the real world of your jobs, how you would respond or how you think patients might respond to these statements. So the first one is, taking an active role in my own healthcare is the most important factor in determining my treatment plan and quality of life.
I would respond to that and say it depends on the generation that's responding. Millennials, I would say yes. Baby boomers, maybe not so much. At least from my experience and what I've seen.
Mm-hmm. From my experience, I think that sense of patient empowerment is absolutely vital. But I also think that becomes more of a challenge as people do age. Mm-hmm. Again, I'm thinking of my 96-year-old mother. She's quite competent. She's quite capable of managing her own care, but it is a challenge.
And I think part of. Okay. Sorry, Mike, you can go.
No. Go ahead.
One of the other factors that I think that makes it challenging is not just age, but is the complexity of healthcare, the healthcare system in general. Exactly. And so I'm a little intrigued by the story that you were just telling, Daniel, about having that one person guide you through just that one particular visit. But if we take that story and apply it to the patient experience outside of healthcare setting, just in general, our patients don't have anything to support them in the real world, outside of those hospital walls, or outside of that clinic walls. And some patients are seeing, 3, 4, 5 different specialists, all from different organizations. And so what can we use in terms of technology? What can we do to help support them in managing the complexity? So we're reducing that complexity into much more simpler, digestible steps that they can be more empowered to manage their own care.
Yeah. Mike,
I was going to add on to that, from the patients we talked to, that just insurance and affordability is a big factor. So they might want something, but their insurance doesn't cover this specialist or this procedure, or they don't have insurance. This is America, we don't have 100% healthcare insurance coverage. It's what between 10 and 20% don't, and those people respond to our surveys as well, and they want healthcare, but if it's something that's going to cost them out of pocket, or even with insurance, if you have a high deductible, I think that's one of the other things we've seen. Deductibles have gone up and up to keep the premiums down, but then that means that something that could be beneficial but might cost you $800 or $1,000 out of pocket is not affordable to every person. And so sometimes people want it, but it's, you know, they're guided by what they're really able to afford or offer to them.
Yeah,
yeah. I think that adds to the complexity too, Mike, though, is that the transparency in our cost, we're not very open about some of the costs. And true story, I know some patients that are insured, but they still don't use their insurance because it's actually cheaper to do it out of pocket rather than trying to meet their deductible. And so how do we provide those options to our patients, again, in the real world, when they're trying to figure out, they have to do a colonoscopy. How do they figure out which one is more affordable, but still have the best outcomes? Because, you know, cheaper healthcare doesn't necessarily mean it's good healthcare, right? So, but and so how do you compare the cost with the how they're graded for providing that level of service? Again, that goes back into that complexity, and how do we reduce that complexity and give our patients the right information at the right time to make those right choices, so they can, again, be empowered to take control.
Wow, very good. Well, folks, I've just really enjoyed this conversation. I'd like to thank everybody for participating. And just to go and remind folks, we have Dan Eds, who's a consultant with Praxis Solutions, Strategic Planning for Healthcare. We have Dr. Michelle Hamlin and Dr. Kim Corey. They're with Inventec Consulting and also in the Informatics group at a major healthcare institution. And Mike Zangrelli, who is head of project management and strategy at 83 Bar. And we've been talking about listening to the data. And anyone who maybe started with us and said, oh, it's a meeting about data, I guess I'm going to hear a lot of numbers. What I've enjoyed about this is you've been translating the numbers. You've listened to the numbers and then told us what it all means and how it's applied both for the patient and for the healthcare organization. And that's been very helpful. I really appreciate you guys participating with us.
Thank you so much, Mark.
Thanks for having us, Mark.
Thank you, Mark.
Yeah, thanks, Mark.
Definitely. And of course, thanks to 83 Bar for sponsoring this roundtable. So we look forward to continuing this kind of series about what are the implications for some of these healthcare trends? What are some of the things tell us about the patient journey, how to accelerate it, how to manage it better, offer better outcomes and a better experience for the patient. So if you have comments or questions or feedback, certainly send them along and we'd like to incorporate them in future roundtables. So I'm Mark Stenson, thanks for joining us and we'll see you at the next program.